Good morning, everyone. Wonderful presentations. Thank you very much. My question, though, is in regards to women and cancers in general, especially of the reproductive system, is it in terms of screening? Because we talk about pap smears, even mammograms and stuff like that, but is it that we do screening in terms of blood tests? Because there are individuals that I know, someone actually just recently lost her life to the fact that she did pap smears, she did mammograms, but yet still she did die of cancer because it went to her ovaries. But she did not do any blood tests for cancer screening or anything like that. But is it a criteria? If not, why not?
Yeah, it's a great question. So the question was related to ovarian cancer and potential screening. So one of the biggest challenges is we do not have any effective screening for ovarian cancer. Now, ovarian cancer, thankfully, is not a very common cancer. In the United States, there are only 20,000 cases a year estimated this year. But again, there's no effective screening. So people think, well, I'm getting my pap smear. Isn't that checked for everything? And pap smears only screen for cervical cancer. It does not prevent uterine cancer. It does not prevent ovarian cancer. And for ovarian cancer, sometimes there's a false belief that, well, I'll get an ultrasound, or I'm going to get the famous blood test at CA125. But those tests do not prevent or catch an ovarian cancer early. The latest study was over 10 years, 400,000 women from the UK who were getting routine GYN ultrasounds and CA125s. And in that group of women, we still were unable to identify ovarian cancer early. And that's why it's called the silent killer. So what women can do is, one, know your family history. And it's something that I'm Cuban. We don't talk about cancer in the Cuban culture, and I think the Caribbean culture, we don't talk about cancer, right? But it's important to know your family history, because if we can identify a family that has a genetic risk for hereditary breast and ovarian cancer syndrome, then we can intervene. And one of the reasons that we think the numbers for ovarian cancer have finally decreased in the United States, it's because we have been identifying these BRCA positive families. And for the last 10 to 20 years, we've been intervening with risk-reducing strategies, including risk-reducing surgery. And so we're finally seeing the fruits of that labor. So there is no effective screen right now for ovarian cancer. But listen to your body. If something doesn't feel right, tell your doctor. And if they're not listening to you, then find another doctor that will listen to you. But unfortunately, there is no screening for ovarian cancer at this time. Another question in the back? Yep.
Morning, everyone. Excellent presentation, everyone. This question is for Dr. John Diaz in regards to your fertility-sparing procedure. Do the women have to meet any criteria in order to be considered for this procedure? That's one. How long after completing the radiation treatment would the woman be qualified for this procedure? And three, how long after the entire procedure, that surgery and radiation, would you recommend considering trying for pregnancy?
Yeah, those are great questions. So certainly there are criteria for who would be a candidate for this. In fact, most of the women who have undergone this procedure internationally have been women with colorectal cancers. And so again, for colorectal cancers, they treat that pelvis with radiation, but the uterus sits right there. So most of the patients treated have actually been for non-GYN cancer. In fact, my patient is the first vaginal cancer that's been described in the medical literature. And so a candidate would be someone who, again, desires future fertility, has a possibility of this, and it really is a multidisciplinary approach in conjunction with the radiation oncologist, our therapeutists, and a fertility doctor to see what are the realistic expectations, right? If you're 45, maybe not realistic that you're going to be able to maintain a pregnancy in the future. So there's certain things that we look at. As far as timing, we'd like to do the surgical procedure about 6 to 8 weeks after completing radiation therapy, before a lot of the scarring from radiation therapy, although not a lot happens under Dr. Weiss, occurs. That makes it sort of easier for us. And then as far as pregnancy, we'd ask for at least a year before patients attempt to conceive. Again, part of this evaluation is seeing a fertility expert, and sometimes they may decide to go ahead and preserve oocytes or embryos for implantation, but it really is a multidisciplinary team, and things like this help us to share this information. Many physicians don't know about this. Many oncologists don't even know this is an option. Again, this was the first procedure done in the state of Florida. Our institution has now done 2. But like I said, in the United States, only about 10 of these have been performed, and certainly more than 10 women could benefit from this. Question up in front here.
Thank you very much. Thank you for your presentations. This question is for Dr. Joseph. You mentioned 3 simple steps for prevention of cervical cancer: vaccination, pap smear, and HPV tests. And you made mention of talking about it, right? In terms of the risk factors that you mentioned sexual history, early onset, and of sexual activity, and multiple sex partners. What other prevention could you suggest as relate especially to that risk factor?
So I think one thing that I did not mention is, I know Gardasil, we always promote, it's a women's health conference, but in addition to women, men, young boys are also recommended to get Gardasil as well, because with HPV, we have it all within us, men and women, but it really is the immune system's job to really catch these virulent strains and to prevent it from becoming a viral oncogene. So I think in addition to adolescents, like ages, I think 10 to 12 is the recommended guidelines for Gardasil, but also including our boys, our sons, grandkids, to also get that. So I think in addition to women, men also would be also eligible to get Gardasil as well.
Hi, good morning. Thank you for excellent presentations. I have one question and I have one comment. The first question, I guess, would be to anyone. Obviously, the whole sort of development of fertility-sparing treatments and minimally invasive treatment is to preserve fertility. Is it that women are starting their families later, or is it that these cancers are presenting at an earlier age, or is it both? That's my question. My comment, I'm going to get controversial here, but my comment really is about screening. We all know the importance of screening. The sad reality is that there are some barriers to women accessing health care, and oftentimes it's a financial barrier. I'm a general practitioner. I talk to women all the time about screening, getting your pap smear done, getting your mammogram done. Unfortunately, because of financial constraints, it doesn't happen for everyone. And we're in the run-up to an election, a general election here in Cayman, in case you didn't know. This one is for the healthcare, those policymakers. With a majority of women having inadequate coverage for their wellness, which is what pap smears and mammograms come out of when it comes to your health insurance coverage, it's not enough. On the basic standard health insurance contract, it's not even enough for a mammogram. Thank God for charities like the Breast Cancer Foundation and the cancer charities here. They help women to get their screening done. But the basic health coverage for women is not enough when it comes to wellness. That's my comment. I'll let you answer the question. Thanks.
So I think that's a very, very good question, but when it comes down to it, I think it depends on the type of cancer. So for example, cervical cancer, we diagnose a little bit earlier than ovarian, for example. So whether it's premenopausal versus postmenopausal. So I think to answer your question, I think it's a combination of both. So women professionals, like Dr. Diaz was mentioning, are having kids a little bit later on in life for example, myself, not any kids just yet, but I just hit 40. But a lot of the time, cervical cancer is diagnosed before this. When it comes to breast cancer, it depends on the histology for the breast cancer, whether it's a triple negative, HER2, or like estrogen, secreting cancers, depends on the age. So it's hard to pinpoint and to give a really direct answer to your question, but I think it's a combination of both.
I think just one thing to add is that there's, I think, also some patients that, as strict as your screening guideline is going to be, that you can have aggressive disease come in between it. When we hear about people that they've gone for their mammograms and they still present with some aggressive triple negative breast cancer, the worst cancers actually can come and grow sooner than the 2 years or 3 years pops up between your tests. And so I think, again, being familiar with your body when there's changes, seeking care, even if it's not at that exact time point, is helpful. I think in terms of the ages that people are being diagnosed, it's different in different places. We're all seeing patients that are younger with colon cancer or with breast cancer, even people being diagnosed while they're already pregnant, which can be very challenging because the drugs you can give, the imaging you can do if there's a pregnancy is all very different. I think at the end of the day, like being able to have a network where you can work within the community and help, especially with the underserviced populations, is helpful. There's even places that have a pap smear truck go around to some communities and try to capture people in more rural areas in the United States where screening is just simply not possible by virtue of the closest hospital or clinic might be miles and miles away. So I think from the public health and epidemiologic perspective, there's a lot of work that can be done to try to increase access, but also noting that for whatever reason, there are some patients that screening will never capture. It's never going to be 100%. In terms of the fertility sparing and whatnot, I think it's an amazing thing that we're able to offer. A lot of the patients we treat come with more advanced disease with a large stage 2 or stage 3 or even stage 4. And so at some point, it becomes a discussion of you're curable, but it's going to be X, Y, and Z side effects, or this is an earlier stage and these are the options. So sometimes we're a little bit stuck in not necessarily being able to offer tons of options or even offer fertility sparing. It's sometimes a very carefully selected population.
Good morning, everyone. Thank you so much for your presentation and the hard work that you do. I really enjoyed Dr. John's presentation. I was remembering my days on gynae and the many complications from bleeding that we had with those surgery. So I really enjoyed your presentation. I have 2 questions for Dr. John. At what's the highest parity these women are allowed to achieve post-surgery? And my second question for Dr. Wise, as it relates to brachytherapy, is there an age specification as it relates to this treatment? Thank you.
Thank you. So we don't have a limit on parity. In the US, on average, we're having less and less children. And so the average family has 2.1 kids. I'm not sure how you get that 0.1. So certainly you can have 2 children. Again, each delivery will be a cesarean section. So, that sometimes limits OBGYNs how comfortable they feel with this. And interestingly, what we saw with our trachelectomy data is there's a lot of guilt and anxiety after a GYN cancer diagnosis, which women should not have, but they do. And so of our initial paper of 42 women who underwent a radical trachelectomy, only 12 went on to go and attempt fertility. And so those are things that we have to work through with our patients. But to answer your question, there's not a limit, but in the US, we tend to have about 2.1 kids.
Thank you so much for the questions, everyone. Dr. Weiss has a comment?
Yeah, she had just one more brief question for me. There's no age cutoff for brachytherapy. It's just one of the tools we have in our toolbox from the radiation therapy perspective. If anyone's not a candidate, it's usually because of other comorbidities. For example, blood clots, they're on blood thinners, and it's difficult to sort of manage that. But those are things we can even sometimes work around. So if there's ever any sort of question, if someone would benefit, it's a phone call or an email away. Thank you for your question.